Hi, my name is Amisha. I'm a third-year Chief Fellow at Moffitt. I'm presenting at ASH 2025 in Orlando. I'll be talking about my study on feasibility and safety of accelerated step-up dosing of glofitamab in rapidly progressing relapsed refractory diffuse large B-cell lymphoma. So glofitamab is 2:1 CD20/CD3 bispecific antibody that is FDA approved for relapsed refractory diffuse large B-cell lymphoma after 2 prior lines of therapy. The key toxicities associated with glofitamab is CRS and ICANS. To mitigate the risk of CRS, glofitamab is normally given in a step-up dosing fashion. The FDA approval was based on NP30179 study. If you look at this figure here, glofitamab is given with obinutuzumab pre-treatment on day 1 of cycle 1 to reduce the peripheral and tissue B cells. Then 2.5 milligram is given on day 8. 10 milligram is given on day 15, and the target dose, which is 30 milligrams, is given on day 1 of cycle 2. So the time between glofitamab, obinutuzumab pre-treatment to glofitamab target dose is 21 days. More recently, BICAR trial explored accelerated step-up dosing of glofitamab, in which 2.5 milligram, if you look at the figure, was given on day 4. 10 milligram was given on day 6, and the target dose 30 milligram was given on day 11. So the time between obinutuzumab pre-treatment and the target dose of glofitamab is just 11 days. In clinical practice, however, accelerated step-up dosing of glofitamab is more useful in patients with rapidly progressing disease with impending risk of organ failure, or maybe if you have to reduce the tumor burden in patients who are going for CAR T or transplant to reduce the delays. Keeping that in mind, we decided to do this study with patients with rapidly progressing relapsed refractory diffuse large B-cell lymphoma. We treated them with accelerated step-up dosing of glofitamab as in BICAR trial based on the need, which was selected by the physician who was treating the patient. So between February 2024 and April of 2025, we had 29 patients who were assessed for eligibility. 3 patients were excluded, 1 had an alternate histologies, 2 died before glofitamab could be given. So overall, 26 patients were included in this retrospective study. If you look at figure here, prior to October 2024, we were just giving IV dexamethasone 20 milligram as pre-medication prior to glofitamab. After that, we started giving 10 milligrams of per oral dexamethasone on these days to further reduce the risk of CRS. So in our study, our patients had high-risk baseline disease characteristics. If you look at figure 3, most of the patients, they had high tumor burden with bulky disease, extranodal disease, they had very poor performance status, they have high baseline inflammatory state, and they have cytopenias. Notably, 69% of these patients would be excluded from BICAR trial. So now talking about feasibility, out of these 26 patients, 3 patients were not able to complete the ramp up because of toxicities, and 1 patient had severe GI bleed due to disease progression. Only 23 patients completed the ramp up. Out of these 23 patients, 20 completed without delay, and 3 were delayed due to toxicities. Now talking about toxicities, if you look at this figure, the overall incidence of CRS in our study was 61%, and 15% patient had more than equal to grade 3 events. Most events happened with dose 1 and they declined thereafter. The overall incidence of ICANS was around 12%. 7% patient had more than equal to grade 3 events, but all the events happened with day 4 and day 6 dosing. So in our study, we mandated patients to have inpatient dosing day 4 and day 6 with a 24-hour minimum observation. However, the median duration of hospitalization was 5 days. It ranged from 1 to 21 days. If you look at this graph, at median follow-up of like 4 months, the median overall survival was around 3.6 months, and median progression-free survival was 1.9 months. And the objective response rate was 42% with complete response rate of 15%. In this study, 13 patients were treated with an intent of bridging. Out of these patients, few were bridged to CAR T. There were approximately 6 patients, and 2 were bridged to allo. So in conclusion, accelerated step-up dosing of glofitamab is mostly needed for patients with rapidly progressing diffuse large B-cell lymphoma. However, these patients have certain high-risk features that cause them to have lower efficacy and higher toxicity. So although it is feasible, we really need future studies to identify which patients would truly benefit from it.